I'm Jane McDermott and I'm here going to talk about complex health ecosystem, but actually I talk from a policy perspective. So I'm very much going to give you an overview of my work within the Policy Research Unit, or our work working very directly with government, and then going to focus down on a more localised approach as well. So first of all, I just need to mention that everything I say is my opinion and it's not related to government or the opinion of government or the National Institute of Health and Care Research, and that's my evidence to say that it's all my opinion. So yeah, I'm just going to make a start and just talk through. So the National Institute of Health and Care Research is a multi-billion-pound research council based in the UK. They are a multi-billion-pound funder of research. They have 9 huge programmes of work, one of which is the Policy Research Programme. The purpose of that is to deliver high-quality, cost-effective research to inform national policy across health care and public health systems. We get commissions directly from the Secretary of State for Health, but also social care ministers, health and social care ministers, senior officials from across the Department of Health and Social Care, as well as ALBs, which are known as National Health Service. It includes 2 areas of work. First of all, a national programme, which is policy-driven, flexible and open to regular input, so people can apply into the policy programme on a regular basis, and that might be evaluating services, looking at the implementation of the policies that have been introduced. Then there's also the Policy Research Units. These are a long-term resource for policy colleagues, and they include a rapid response service, all of which provide evidence in really high priority areas of health and social care. It's a pretty significant investment. They've been going since about the 60s and 70s in a much smaller version, but in the last 15 years they've really grown. So the investment at the current funding is about 75 million. And yesterday they've announced, which is why I'm allowed to talk about it today, that we've got another 5 years, and that's 100 million from 2024 to 2028. So what do they look like as a set of units? So they cover a range of different areas. So you have specialism specific, and you can see the types of specialisms that they're around policy innovation and evaluation, behavioural insight, social sciences. They're very much directed by the system. So there's a huge area around health and social care workforce, public health, adult social care. They're committed to life course, and that's where you can see us. And we were the Older People and Frailty, or we are currently the Older People and Frailty Policy Research Unit, but we are soon to become and rename the Healthy Ageing Research Unit. And then they've got some condition-specific areas. As we're life course, we do actually cut across all of the areas with the PRUs. And you'll see there in purple, they're the new PRUs. So what makes up a PRU is very much academic experts from across the UK who act as a specialist arm of expertise for government. So that's how we work. Traditionally, quite often government tend to have a series of advisory boards, but this is a much more integrated structure. So we are there to work really closely with policymakers all the time, a really regular basis, and we're funded for a 5-year period. So the research themes are what you would expect in an Older People and Frailty Policy Research Unit. So we've got population change, we've got ageing, frailty, end of life, and then there's a series of cross-cutting themes as well, which you can see across the bottom. Again, what you'd expect, healthy ageing, but certainly financial constraints and the cost of living crisis in the UK is having a massive effect on older people's health and well-being. This was a decision one of our ministers made, and our Prime Minister last year, that set us into a very rapid downward spiral, but also inequality. And finally, the biggest swear word in the UK, beginning with B, which I don't need to say to you all. So these are our cross-cutting themes as part of the PRU. So how do we work? We work with big data and with evidence, and that's about 60% of the work that we do. Projects that run for sort of 2 to 3 years, but also qualitative primary research. We do a range of different types of work. So that's roughly 60% of our programme. We are now deep diving into a co-creation period with policymakers to develop the programme of work for the Healthy Ageing Policy Research Unit starting in January. But unusually, 40% of our work is rapid response mode. So rapid response mode can vary to the Minister needs to know by Friday what is the best knowledge or expertise we have related to strength and balance interventions for falls prevention, for example. So we've got a week to turn it around, or 5 days, or 3 days was the shortest. Or more commonly, it might be, you know, we need to know in the next 2 weeks the answer to this policy question. So things that arise within policy team across government, they come to us and ask for information about how to address rapid responses. And usually the longest of those is about 3 months. So up to 3 months to answer the questions. And we typically will meet with them. Okay, so this is our responsive mode and this is how we work. This is really different than usual research. It requires a whole different set of skills, a really different way of working as well. So the ideal responsive mode is across the top there, where, you know, there's a policy gap, they'll come to us, request, the team review what the request is, we sort of find out, do some scoping, has it even been answered, can we even answer the question? And then we spend a lot of time meeting with the policy teams and really trying to drill down to understand what they really do need to know, whether it's actually answerable or whether we need further research or what needs to happen. And then we tend to, we'll work out how long that will take, identify the capacity, and then we'll get that delivered within the time frame. And then in terms of dissemination, as soon as we've got that sign off from DHSC, and everything has to be signed off by them, so we have a no surprises clause because we're working with government, we then get that information out to everybody. So it goes to local, national, regional government, goes really broad and wide, because we have, you know, we are spending public money and we have a responsibility to make sure that we're disseminating everything that we're producing for the DHSC. So there's not a lot that remains private or in closed doors, only whilst we're working on it. We can't talk about it too much. But what I've got here is a little bit of an example of what a rapid response piece might look like and how it happens. So the Women's Health Strategy, there was a call for evidence, a national call for evidence, which is what lots of government do, looking at women's health. It was the biggest response they'd ever had for any call for evidence. They had 110,000 submissions for women's health. And when they did the analysis on it, what they realised was there was a significant gap in terms of women from ethnic minorities and also women who were older, so older than about the age of 60. And so they did a research request. They came to us, we're the older people and frailty policy research unit. We need to understand women's understanding of their own health and what they need in terms of health. So we did a collaboration project with another PRU. We came together, they dealt with women who were younger and midlife, and we did the older women groups. We did a series of focus groups. So we really quickly delivered this project. It happened in about 3 months, really rapid. We ran, I think, 14 focus groups with different groups of women and then produced 2 reports. One that was more generally around what all women want, and the other one was specifically around older women. Once we'd finished that project, it then went immediately into the Women's Health Strategy, and it all happened in about 4 months. So for any academic to go from here to there in 4 months into a policy is an absolute dream, really. I mean, that's the gift, it's the ultimate gift. And I think as a PRU, it's really wonderful to have such a big team, especially of early career and mid-career researchers who get the opportunity to do work on something that's going to land straight into policy. So that's how we work really on rapid response pieces. It is about 40% of our work. You know, it can be stressful, things move around, you know, you get all sorts of requests, it's quite interesting, but it's all about the relationships that we're building with government all the time. So our stakeholders are vast and wide. This is a really small view of who we work. Now our main customer, and I call them a customer because they are a customer, are the Department of Health and Social Care, and linked to NHS. But of course we have lots of other people that we need to disseminate our work to. We also need to understand what's happening across the health and social care landscape, because one of the things that really helps us with rapid response work is doing lots of horizon scanning so that we can almost predict what we're going to be asked. And we need to do a lot of that. So we work with the think tanks, and these are here, so we were always looking at what the think tanks are talking about, especially around health and social care, gives you a really good idea of what's happening. We work with the huge big charities, and I know Liz is here, Again, that's understanding what's happening for older people, what's going on in their lives in terms of health and social care. We also work with the NIHR infrastructure, and to mention, so Chris Todd, who's not here, but I know lots of people know Chris, he's the director of the Policy Research Unit, but he's also one of the co-directors of the Applied Research Collaboration. And just to give you that understanding, so we're the policy group, but then you have the applied research collaborations, and these are regional collaborative projects which have all the anchor institutions, health innovation, they have the universities and all the hospitals, and these are all the implementation arm of policy research. So it's a really interesting kind of model about that macro-micro. I've jumped ahead. So that's how they work. And then another area that we really work with is local government and regional government, because as I'm going to talk about now, some of the big challenges we have is influencing policy, and actually really that women's health one was a dream, but it's not always like that. So let's get to some of the complexity. I spoke to Beatrix, and she said, talk to us about how the complexity. So I think ultimately one of the issues that we have is that ministers think that this is how we deal. So we deal with the A to B. It's really quite simple, solving health problems. It's quite technical. It's kind of based on an engineering model. It shouldn't be that simple, A to B. But the reality is that we live in a very different world, and we know that about health and social care. So we're not making donuts. It's not that simple. That's certainly not what this is. It's not just a general, simple problem of working in a donut factory. It's a production line. People travel through the NHS. Instead, what we're doing is we're dealing with highly complex systems, adaptive systems. And this is a model of the system of obesity in the UK. You know, it can't be understood by reducing it into really small parts. It's really dynamic, it's really adapting all the time. It has to interact with the system in order to be able to really understand what the causes and effects are, and the whole of it is more than the sum of its parts. So to be able to address that, it's not just, we do need national policy, but it's not just individualised behavioural interventions. It's actually much broader, and they actually only represent a very small part of what makes good health. We need to think about the social structures around that, the environmental structures, and also the policy structures. So that's one of the real challenges that we have. The other thing, which is very much always a challenge, is that we live in a VUCA world. So it's volatile, it's really, really volatile. So things change frequently, quickly, and with significant impacts. And that, for us, is very much around ministers. We've had 5 healthcare ministers since the beginning, and every single one of them has their own thing that they want to show. They've got their own 100 days. So having that change constantly can be really challenging. So we may get a rapid response request in, we may be working on that research, but then at the end of it, it's the policy window suddenly closed because it's been renamed, or it's a different area of interest, or the minister doesn't want that to happen anymore, or we've got a new minister who now doesn't want to focus on dementia, wants to focus on multiple conditions, for example. So actually that change in mood is actually really quite influential in terms of the work that we do, and it can be frustrating. Uncertain, so we really lack sufficient data to make perfect diagnosis, predictions for disease, and also for those underrepresented. And this is really important. So a lot of the big data sets we have are based on white men. So there's a huge lack of data insight, and I've done a lot of work around women's health, but actually around women don't take part in trials at all. Women from underrepresented groups certainly don't take part in trials. So we actually have very limited data. We don't understand how they behave, we don't understand their illnesses, which therefore we don't understand how they present with CVD, for example. What are their symptoms? What's the most appropriate diagnosis and the most appropriate treatment? We just don't know. So that's really, really challenging for us, and especially those from different minority ethnic groups, and massively challenges that we just don't have the data to tell us the story and help us to understand how we should best deal with those groups. It's all based on white men. It's really ambiguous as well. There's a really bewildering number of variables, you know, and they're all interconnected. So trying to kind of deal and managing that complexity is really, really challenging. And finally, complexity, the situation, the problem, the data, it could be interpreted in loads of different ways, and it just presents lots of different challenges for us, but it's not all bad news. So I'm now just going to talk about a regional project or a regional piece of work. So Greater Manchester had health and social care devolution. So big government decided that actually we're going to let and see what happens in Greater Manchester as one of our regional partners. So we had devolution of health and social care in 2015. It was a £6 billion budget. Okay, so we've got 28 million residents, 1 million over the age of 50, our life expectancy, 17 years between the richest and the poorest, and the highest number of COVID deaths in the UK. It's quite a bleak picture. We are an age-friendly city region. So Greater Manchester were given devolution, and because I've got 1 minute left, I'll be really quick. It's been enormously successful. I mean, it was a win-win for government because if it didn't work, they could blame us because we're a Labour GM, Greater Manchester. If it did work, they could take the glory. But what they've actually done is that it did work, and we are now reducing disability-free life expectancy and reducing the gap between the richest and the poorest. Very quickly to say, this is the approach that we've taken here. It's kind of very much a wider determinants approach to health, understanding all the collective issues that influence health, major shifts in mindset. I would recommend this book if anybody wants to read it, a really interesting eco-view, looking at a garden mindset, and it's very much how the leadership has moved and the model has moved in Greater Manchester towards an outward focus, very much towards collaboration. And we've been so successful that the Health and Care Act in 2022 rolled out the whole model of devolution. They're not giving devolution, but what they've done is created 42 integrated care boards, all with that really similar model that we were given in Greater Manchester. So I'm going to stop there. For those of you that are interested, you can share my thing. And this is more for the teams, and this was just to kind of think about the leadership skills that you need when you're working in a volatile VUCA environment. So you can just maybe have a look at that another time. So I think my time's run out. Got to stop. Thank you.